Hello there. On behalf of AT&T Business, thank you for joining us for today's Virtual Viewpoints webinar. You're in for quite a treat. Our speakers have an engaging and insightful discussion planned for you. This webinar will be recorded. We'll send you a link with the recording by email within 24 hours. Before we begin, let's go over how to make the most of your experience. Each window on your console is resizable and movable, so feel free to move things around as needed. At the bottom of your screen are tools to enhance your experience. They're customized for each webinar. Options usually include a link to contact us directly and a list of resources for today's webinar. We'll also include links to related webinars if available. We invite you to download these resources or click on the links that you find most useful. Feel free to explore these tools at any time. If you click on them, you'll still be able to view the webinar. Lastly, please take a moment to fill out our survey during or immediately following the webinar. We craft our content with you in mind, so we'd appreciate your feedback. A window will pop up immediately following the webinar, or you can find access to the survey in the toolbar. And now I'll turn things over to our speakers to kick off today's webinar.
Hello, and welcome to the Next Level Virtual Care. This is a conversation with three experts from diverse backgrounds, but all with the same mission: to improve access and outcome in today's chaotic healthcare system. Our program today will discuss how hospital at home is transforming care and what it means to you. My name is Monica Stinchula. I am the Director of Clinical Operations at Constant Companion, and I'm thrilled to be your moderator today. It's time to meet our panel. Lauren, would you tell us a bit about yourself, please?
Sure, thank you, Monica. My name is Lauren Faison-Clark, and I'm located in Tallahassee, Florida, where it's actually quite chilly today. But my role at Tallahassee Memorial Healthcare is I serve as the Director of Regional Development, Population Health, and Telemedicine. And in that role, essentially what I do, both in the inpatient and outpatient environment, is help people get to the right level of care in the right location.
Thank you. Next, it is my pleasure to introduce Tim McNeil. Tim, please tell us about yourself and your organization.
Yes, good afternoon. My name's Tim McNeil. As was stated, I'm with Freedman's Healthcare, and we provide complex case management and home-based primary care with a heavy focus on dual eligibles, persons with comorbid behavioral health and chronic physical health conditions, and a functional impairment.
Thank you, Tim. Our third panelist comes from Dispatch Health, whose meteoric expansion has the attentions of all of us. Dr. Nealon, or Patrick, please take a moment to tell us about yourself and your organization out there in sunny Colorado.
Yeah, hi everybody. Patrick Nealon. I'm an internal medicine physician by clinical background, and I've spent my career working to make the system work better for ourselves and our communities, as well as for our colleagues in healthcare. I'm at Dispatch Health, where I'm the Vice President for Medical Affairs, and where I've built and lead our advanced care program, which provides inpatient level care inside of patients' homes. It's a pleasure to be here today.
Thank you, Patrick. We did have a fourth panelist, Mary Mayhew, the CEO of Florida Hospital Association. Unfortunately, Mary got called at the last minute to give testimony in front of the Florida legislature, so therefore she's not with us. I want to start a conversation by learning more about you, the audience. So this isn't the new SAT online. This is simply to find out where you are when it comes to hospital at home. So here's our question. Is your organization actively engaging in some form of hospital at home model? Yes, no, don't know, or does not apply? We'll give you a few seconds to weigh in on it, but we really want to hear from you. It's important for us to know who's out there, who's listening to us today. I see the replies coming in. This looks good. We're still waiting on a few more. And I think we have the results. So let's see. Yes, most of you are already engaged in hospital at home. This is terrific. I think you'll really enjoy listening to our speakers and learning what they have to say about hospital at home and comparing it to your own knowledge. So let's get on to that. So our first topic today is, what is hospital at home? We know that there's a lot of collaborations that are happening today and forming different hospital at home, but we want to hear from our experts here. So the members of this panel have diverse backgrounds, but they all believe in hospital at home. Tim, let's start with you. Would you tell us about the population you serve and why hospital at home fits your mission?
So absolutely. So we collaborate with hospitals and accept their most complex patients and assist them with transitioning to the community, with a heavy focus on those persons that are dually eligible, that have multiple chronic conditions, as well as they may or may not have a comorbid behavioral health or substance use disorder. As I describe that population, you can imagine that that population disproportionately suffers from a wide range of social determinants of health. So we work with a network of community-based organizations that are generally led by a network lead entity in the community as our partner to address the full range of needs a person has to provide both clinical and social care to meet their needs so they're stable at home. And so it's a full wraparound service.
Thank you, Tim. Lauren, let's turn to you. Your company works with a variety of settings. How are you deploying the hospital at home model and incorporating telehealth in that?
Well, in your introduction, you talked about chaotic health systems, and I think we would all agree, never has that been more true than in the past 2 years. But even prior to the beginning of a pandemic, we operate a transitional care center, much like the services Tim was just talking about, because we know patients do better at home. And in order for their long-term health, we need to engage the people in their surroundings, their family, their loved ones. We need to see what their environment is like at home so we can teach them how to be partners in managing their own health. And right now, when we have such critical capacity issues, we have no choice. And so this necessity is really driving the innovations we've always known would be a better practice, but now we have no choice to do it. For example, today we started our day with 27 patients in our ED waiting for a bed. And I had 3 rural hospital CEOs calling me begging to accept transfers. So when you get in this gridlock of not being able to accept patients that need to come to a higher level of care, we've got to help that throughput and take care of patients that are appropriate at home. And we can do that with a lot of case management and other services.
Thank you. Really appreciate that. You paint quite the picture of what's going on there in the Tallahassee area. Thank you very much. Patrick, Dispatch Health works across all populations, from commercial insurance to government programs. Would you please describe Dispatch Health's hospital at home model?
Yeah, and I really appreciate the question that's on the slide, which is, what is hospital at home? Because I think there's a lot of conversation going on around the country about what that is. Our version of hospital at home is truly aimed at substituting it for the inpatient stay as a way to provide wraparound services, much like Lauren and Tim described, for patients to get them through that high acuity illness in their home. And then to continue to support those patients in their home for the next 25 to 30 days, really making sure that they're teed up for success, both from a health standpoint, but also in all these other contributors to health, such as social determinants and other levels of support that are so important for people staying healthy at home.
Great. You know, I heard it from all of you that hospital at home is increasing the quality of care and the continuity of care, that's your goal with doing this. And that's a real win for healthcare consumers. We know that we need to reduce the fragmentation in our system today and increase the trust with our patients. Optum did a survey and they said that 4% of consumers have experienced in-home care in 2020. Today, 75 to 85% say they want to get their care at home. And that would be care for sick visits, for illnesses, for replacing a hospital stay, for chronic care visits, wellness checks, and physicals. So there's a lot, to Tim's to Patrick's point, there's a lot of variation on what people define as hospital at home right now. But let's turn our attention now to the barriers, that what's keeping this from really taking off the way we think it should. So the first question is for you, Patrick. What is the biggest barrier that's slowing your growth at Dispatch Health?
Yeah, thanks. And to the point, I think if we set out to say our goal is to provide a complete continuum of care in the home, which it is, what we're doing at Dispatch Health and building everything from replacing emergency care to post-acute care like SNF substitution, but also that inpatient substitution. It's probably not a surprise to anyone in the audience that one of our major barriers is the workforce availability. I think all healthcare hospitals, clinics, regardless of what sector you're in regarding to healthcare, the workforce, in particular nursing workforce, is a really important thing to be focusing on. And I'll use a minute to plug for the heroic nature of the care that our nursing colleagues have been providing through the pandemic, and to continue to advocate for compensating that work in a way that keeps people in the profession and allows for us to continue to fill that really important need. If we're really going to focus on keeping patients home and healthy at home, we are going to need to double down on that.
Thank you. And thank you for that call out. I really appreciate it. Panelists, I'll just remind you to mute your phones so that we don't have any disruptions when someone else is talking. Patrick, you're absolutely right. We need to be supporting our nurses, and it's frightening to see how our first responders and nurses are suffering right now in the pandemic. Lauren, to you. You're there in the panhandle of Florida and South Georgia, working in critical access hospitals. Easy for you. Yeah, thank you. And a large hospital system. What do you see as the barriers to virtual care for you there in Tallahassee?
A lot of it, I think, and this has been an issue for a long time, is a culture shift of not being a provider-centric care environment, but really pushing the care into new environments and using our clinicians and our clinical experts in different ways, where they can be at a computer and seeing patients in multiple locations and really pushing that care out. Again, going back to a capacity issue, we immediately had to provide specialty support to our critical access, and rural hospitals around us in order to help them keep patients safely and help them maintain that care, because we had no ability to take them. And so really changing that culture of understanding where we can plug in and fit the holes for other partner facilities is a culture shift. And so that takes time, and you really have to build those models.
Thank you. And thanks for sharing your struggles with the limited resources that plague our ability to supply high quality care right now. You're right, staffing and culture are two big issues. But let's turn our attention to the regulatory landscape. And Tim, we're coming to you first. Tim, being that you are an advisor to CMS, what do you see coming in the future for telehealth, transitions of care, and remote patient monitoring regulations? Where are we and where are we going with that?
Thank you. Just to clarify, I'm not formally an advisor to CMS, but I do work very closely under HHS with the Administration for Community Living. And we've been tracking for some time the CMS, the release of the CMMI, the Centers for Medicare and Medicaid Service Innovation Center, the release of their strategic refresh. And that strategic refresh sets forth a goal to move 100% of the Medicare and Medicaid population into an accountable relationship by 2030. In order to do that, then there's going to have to be a significant expansion in the care delivery models to support providers to move into a risk-based payment model with a particular focus on the vulnerable populations, because that was also cited in that regulatory refresh that accountable care relationships haven't fully extended to dual eligibles and Medicaid populations to the extent that it has others. Well, that population, as was described in the earlier conversation about barriers to broadband, well, if I look at populations that are dependent primarily in HUD-supported housing, have limited financial means, whether they're in urban or rural settings, their access to broadband that could support a telehealth visit, for example, is non-existent. Amongst our dual eligible population that we serve, the majority of them have a FCC subsidized phone that can't support a telehealth visit because they're flip phones. And so how can I expand access to a person with functional impairments who has a flip phone that's a 3G flip phone in 2022? I'm going to need some support to make that happen.
Thank you, Tim. Boy, you really highlighted the role of technology in healthcare today. They're not two separate industries anymore. We're all in this together. And we do have some culture change to address. And thanks for all those insights. Patrick, on to you. You know, the Biden administration has extended the public health emergency for another few months. So that means the regulations are a bit more laxed. How is that easing impacting your business today?
Yeah, and I think as we think, through the past couple of years in the COVID pandemic, there's been very few silver linings. But one of them is probably this, in that the spotlight around being innovative and finding ways to provide technology-supported care in the home has really turned on in full, and there's been a real focus on it. And a big part of that has been the easing of the regulatory landscape. And that's allowed us, like so many others, to engage hospital partners, communities, et cetera, to deliver this care more broadly, to really help to support throughput and other elements of hospital-based care that have been so limited during the COVID pandemic. Overall, I think it's been a really important step. I think most of us are hopeful and optimistic and expectant that we will continue to find ways to move this innovative perspective forward in regards to the regulatory landscape.
Thank you, Patrick. You know, I hear both of you talk about the role of technology and changing the site of where we're providing care right now. And it emphasizes the importance of those transitions of care and extended hospital at home care that you're providing right now. From my perspective, that requires us to use technology 24/7 to build those trust relationships between the patients and the providers that are doing the home-based care models for this to be successful for us. So that takes us naturally on to talking about technology as closing these gaps in care. So let's move right on to that. You know, at Constant Companion, we believe that technology has the power to transform who and how care is delivered. According to VoiceBot, 21% of people have tried using a voice assistant device for healthcare services, and 56% are interested in doing that. Voice is one of the most powerful technologies and easiest to use for whatever segment of the population you're working with. And that's where we see great promise coming in the future. So Lauren, let's go to you. Lauren, when you think about the social determinants of health that both Patrick and Timothy were just discussing, how are you deploying technology to close those gaps in care? And what does that do to quality for you?
Sure. So we are, as I was stating before, we're meeting patients where they are. So access has always been an issue, but we are surrounded by very rural communities, and that access is tenfold. When there's no public transportation, there's no accessibility. We don't want geography to determine the quality of your health and the quality of your health care. So we're figuring out how to use very simple technologies to get to care where it's needed. Working with the system of post-acute facilities, our federally qualified health centers, and social service agencies. We opened a hybrid clinic, a virtual and in-person, at our big homeless shelter here about 2 years ago. And it's been very successful because it's very accessible and it's right there in their environment. What people consider as home is a very different definition for different people. So we have to meet them where they are and provide that access to build that trust.
Thank you. That is a great point. So it's not just it's not technology for the sake of technology, but it's technology that follows the person where and when they need the care.
Exactly.
I like that. Tim, from your work with the area agencies on aging and community-based organizations, what do you see we need to do to supply these critical populations? And what technologies do you think we need to deploy to close these gaps in care?
Sure. So when you speak about the work with community-based organizations such as the area agencies on aging, when you're able to combine a medical plus social care so that both are working synergistically together on an equal footing, not that one is more important to the other, then you're really able to meet the needs of populations that are negatively impacted by social determinants of health. I think the pandemic has really highlighted when we saw our neighbors sitting in mile-long lines waiting for food, that the impact of social determinants of health are all around us. We didn't realize it. And so there's real struggles that people are facing. And so this leveraging technology to coordinate with a network of community-based organizations to meet the medical and social needs, it really has a tremendous cost benefit to the healthcare system. One example is we worked with a group of beneficiaries who were not able to access their insulin. Their A1Cs were all greater than 13. And by coordinating with the Area Agency on Aging, we were able to identify that almost all of them were qualified for a subsidy that they didn't know existed. And so now that subsidy allowed them to get their insulin, and then there was a precipitous drop in their A1Cs and outcomes. So it shows that identifying and addressing social determinants of health as a partner with community-based organizations is not just a feel-good thing. It was real dollars and cents and a benefit behind it.
Oh, I couldn't agree more, Tim. As a lifelong social worker, you know, you're humming you're singing my tune. I have to agree with you. It is the synergy between them. It is us working, as all of you have said at one point so far, wraparound care. How do we wrap this around each other? I want to share with you what we're doing at Constant Companion. You know, today, most healthcare professionals have some kind of HIPAA-compliant device that they're using, right? Whether it be tablets and EMR, whatever platform they're on. But that's not the same for all of the end users, whether you call them patients, clients, whatever nomenclature you're going to use for them. They don't have access to the same level of secure environment to be able to do this. So that is why our company is partnered with AT&T to offer cost-effective, HIPAA-compliant, easy-to-use technology to level the field in virtual care for all of those end users, for all of those patients out there that need the coverage. And we're very proud of doing that. It's time for a second poll question. So for all of you that are multitasking and working on your email at the same time, look back at the screen, because we want to know from you, which geographic segment do you believe used telehealth the most when CMS lifted restrictions due to the pandemic? Do you think it was rural areas, small cities, or metropolitan areas? Weigh in. What do you think? We know that telehealth, I mean, the amount of telehealth that jumped during the pandemic has been incredible. And my hope is we never go back to pre-pandemic levels when it comes to that technology. But who actually was using that technology? You know, what demographic was actually able, or a geographic area was able to do that? Oh, we're getting a good response. I'll give you just a few more seconds. It looks like we have most of them in. And now, what is our result? Wow, most people decided that it was in metropolitan areas. And you know, you're right. That's what we found. You know, Becky Noreen of DataWell was on the virtual care town hall yesterday, and she talked about this statistic. Her research has found that metropolitan areas were the ones most likely to use telehealth during the pandemic. Maybe that's because metropolitan areas have better internet for the most part, that they had lockdowns, and so they were prohibited from going out as compared to smaller cities and rural areas. And generally, maybe it's just the lifestyle factors around it. You know, it's important to understand what data we have and what data we need to really understand who and how technology is being used in healthcare. And that sends us on to our conversation about analytics, which is really important. Panelists, my next question is about data. It's a three-part question, so here we go. First, I want you to share something that has recently changed to make healthcare better, then something that needs to be changed to get us to the next level of healthcare, And then the third one, what data do we need to make that happen? How are we going to measure this? Tim, I'm going to start with you. What do you say? What
Great.
do you think needs improvement, where we're doing well, and then what data we need to make it happen?
Well, I think where I think we've done great strides is a focus on the integration of behavioral health. That has far too been underlooked, both behavioral health and substance use disorder treatment, particularly amongst the Medicare population. In many cities, we're finding that those that are dying of opioids, it isn't just young kids, it's older adults as well, and there aren't good treatment programs for that population. So as we begin to integrate more, I think that we're really moving to a whole person care model. And if there's any challenges, it needs to be, how do we expand and proliferate the full integration of medical, behavioral, and social determinants of health? Too often this is operating in a silo, even in many health systems. You go to the psychiatric unit, which is off someplace, but oh my gosh, they got congestive heart failure. I now have to move them to another unit so they can get that care. But what about their behavioral health condition? When do I move them back? It's madness. We need to really move to a model where we're looking at whole person care, and it doesn't just operate that way in the hospital setting, it's operating in communities as well. And that's why our organization in particular, we have a keen approach to focus on whole person care that incorporates medical, behavioral, and social determinants so that whole person care is met.
And so how does data fit into that?
Oh, yes, great point. So data really drives that, where we are able to understand the needs of the population and then identify the resources to meet those needs. And then we can really have a proactive approach. One example of that is in the District of Columbia. And based on the data, we found that the majority of persons who died from opioid deaths, based on the data, were people over 60. And when we looked at the treatment programs for opioid use disorders, there aren't a lot of opioid programs that focus on persons that are homebound over 60. So we instantly said we need to have a different approach to meet the needs of the population. And that itself will drive down unnecessary hospital utilization. So that's a way that we took a data-driven approach, identified gaps in the market, coordinated with community-based organizations that were rising to meet that need to deliver an integrated medical social model of care.
Thank you, Tim. And that was a great illustration. Lauren, over to you. Can you give us a similar example that in your work there in Tallahassee?
Sure, and I will echo Tim's point of the need to be a more integrated system. And I know in our community, unfortunately, this pandemic forced us, to take a very big step, which is a positive step, to really break down the beginnings of some of those silos. I remember when we were all standing around in an empty parking lot, between the clinics, the hospital, our insurance, payers, everybody standing there figuring out how are we going to set up a testing site for our community and who was going to have what role and how do we all refer things through the same system. And it was suddenly we were working as one instead of in these little buckets where we were shifting patients to. And I think getting that at the core, you can really start to move some of those efforts forward where you really do start to provide that whole person care to the patients. And it takes that sitting around a table together in a meaningful way, not just a way for a PR way, but in a meaningful way to figure out how do we do this in a better way? Because there's lots of need and only so many resources. We all have to figure out our piece of the puzzle and figure out what we're best equipped to do and what resources we have. And the nonprofit community is a huge piece of that. And bringing them to the table and how do we work together to complement each other instead of compete or have these gaps. I think. Go ahead.
In a case like that, Lauren, I just want to circle back to the data element of this. In a case like that, what you're demonstrating to everyone is the value of that collaboration with the data that you're collecting, right? I mean,
Absolutely.
Everyone benefits when they understand we work together and we were able to do this in a more cost-effective, in a more comprehensive way, and data will show us that.
And we have to keep that going forward. It's too easy for people to go back to the old way. And, you see that in some places, and we want to keep going forward. We want to keep some of those initiatives going because we can't operate in the old way. There's just too much need. And the data does show that. We do a lot of work looking at claims data and looking at what kinds of care people need. You have to know your community. And our community might be different than the one 2 counties over, and figuring out what do our patient populations need and who's best equipped to serve them and how do we get people to those services. And it takes some really intense data review and some planning to make those things happen and make sure those services are available.
Thanks, Lauren. That was terrific. Patrick, we're going to switch now to innovations in new technologies. So I wanted to talk to you about, it's no secret that our world is moving to AI, voice technology, remote patient monitoring, 5G connections, all of these great things that are happening, including AT&T's own first aid platform for first responders. I mean, the amount of technology that has come into our world is absolutely amazing. But what does it mean for you at Dispatch Health? How is technology driving your business?
Yeah, great question. And I think in terms of one of the things that is giving so much optimism to the regulatory landscape shifting and the paradigm shifting to what can be provided in the home is because of the enablement that technology allows to provide that care to reach different patient populations in different ways. I also think and would echo, Tim and Lauren's comments around meeting people where they are, and acknowledging and being really thoughtful as we roll out new technologies, which many of them have huge value add, that we are paying attention to where the patient is. And we've been astonished in many instances the effectiveness of an old technology, the simple telephone and building the human connection over the phone can provide for patients and really go a long way. So again, making sure that as we integrate technologies into these models of care, that we are really thoughtfully integrating them and that we're measuring the impact in proving the value add, which in many cases is not hard at all to do. So really exciting and optimistic horizon here around the introduction of innovation, and let's be smart about how we integrate that and thoughtful about where that innovation is truly adding value and where it's not. That's
right. Thank you. Well said. Very well said. Let's go on to our last poll question. Okay, this time it is the SAT. Are you ready? We have time for one more poll, and here it goes. Which of the following reasons, I can't read. Which of the following reasons for expanding hospital at home programs do you feel are the most critical? Expanding access to care, providing new options for rural care, for rural areas, preparation for future pandemics, hospital healthcare cost savings of the $10 billion spend, reducing overcrowding in emergency rooms, improving how we provide care, or all of the above. Man, that sounds like a Christmas list to me, if you ask me, in healthcare. There's so many things to be done. It's that feeling like buying an old house. There's so many things to be done, you don't know where to start first. Wouldn't you agree? But what is your feeling on this? What do you think hospital at home programs do that is most crucial? Oh, we're having a good response. Oh, good. I scared you with that SAT comment, didn't I? All right. I'll give you a few more seconds, and then we're going to wrap this one up. And I think we have all of our responses in. Let's see how we did. Wow, all of the above. Well, you're not going to get an argument from me. And I don't think you'll get an argument from our panelists as well. I think what you've heard from our panelists today is so important. It's not technology for the sake of technology. It's technology for the sake of creating better human connection, building trust in these relationships, and then moving care to where the person is. So now we're going to move on to our last section where we give our panelists the opportunity to share some pearls with you. And first, before I do that, I just want to thank all of you on the panel. I mean, your insights are amazing, and I can't thank you enough for sharing them. But what is one takeaway that you want to leave with the audience to move them forward with hospital at home? Let's start with you, Tim.
Sure. A key takeaway is using a data-driven approach to identify the populations that will best benefit from a hospital home model is key. And once you sat down and stratified that population, then really moving in a direction where everyone that meets that criteria is almost auto-enrolled to go into the program, so that you really get the scale and benefit. If it's not a data-driven approach to identifying those persons, then you don't see the full benefit of the intervention.
So I had the impression, Tim, that you're implying that some of the neediest people are hiding from us.
Or sometimes they're there, and it's just like the long lines for food insecurity. Maybe the discharge planners or hospitals may think, well, maybe this person doesn't need that much help, but they don't know the dilapidated state of the home that they're living in, which is often causing that readmission. And so if we establish a criteria that everyone who meets these parameters is auto-enrolled, it takes out the decision bias where we may be looking for people who express a need, but miss those people who didn't express it. And so by doing that, you're able to see a broad impact on the intervention by making sure that everyone that meets a certain criteria goes in or is referred into a hospital at home model.
Thank you, Tim. Thank you very much. Lauren, next to you, what's your key takeaway, and what is it you want to see from healthcare in general and policymakers to make the lives of those that you serve better?
Go back to your Christmas list. I want to go back to what you said about technology, not just for the sake of technology. We know at the core of high quality healthcare is that human connection, whether it's to talk about their situation at home, to teach them how to take the medication, or to talk to them about their own behaviors that may be inhibiting their good health. And a technology is a wonderful tool to enable that human connection when you can't be there in person. It's not fair to people to miss out on that because they can't physically get to you. And so we would like to see some of these doors that have opened, like reimbursement. In Florida, we don't have parity legislation, which mandates reimbursement for telehealth. We would like to see some of those things codified in law so they can't take it away, because now the consumers, the patients have had a taste of it. They want it. They understand they can go to their church, classroom and do their diabetes education class, or they can, see their sick mother who's at home in hospice can see their hospice nurse virtually when they're not there. We don't want to take that away from people. It has done so much good, and it's shown how easily it can be done in a very short period of time, that we want to keep that momentum going forward. At the start of the pandemic, we had telehealth as a lot of side projects. We had some places where it was happening here or there, but it wasn't across the whole continuum because of the reimbursement challenges, and people were too busy to deal with it. When it came to that, they had to use it because there was no other way for them to see their patients. It suddenly opened everybody's eyes to the value of the technology. And by having the people, the processes, and the technology all come together in a very concentrated point of time, now we're using it across our entire enterprise. And we need to make sure that that's sustainable and that we continue to capture the value, both financial and the outcomes data, to show that it needs to stay.
Thank you. That was excellent. Maybe you should have been in front of the Florida legislature today. Thank you for that.
My turn.
Next, on to you, Patrick. Patrick, your organization is growing so fast. In fact, you were just featured on an NPR story that we put the link on the site here too. It was fantastic, talking about the rapid growth of hospital at home and actually following one of your teams around. That was really cool. But for you, what's your key takeaway today for everyone to understand about hospital at home and where Dispatch Health is going in the future?
Yeah, and I think, And thanks for calling out the NPR story. That was our rock star Phoenix team that was featured in that. And
it was great.
Great group of people taking care of a patient who spoke really eloquently about the impact on her. And Tim is so right in that as a clinician, there's actually no better place to really understand the patient's whole health than to be in their home and to make those connections between, all right, this is what the evidence says. This is what's going to be practical, though, in your environment. And how do we connect those things? And by the way, how do we connect the resources that you may have in a benefit that you didn't even know you had, or that you haven't been able to speak up around a need or haven't wanted to for whatever reason? Now we're going to start connecting those dots. And I think that is where a lot of the promise is for the types of patients that was in the NPR story a couple of days ago, but even broader than that. So I think we're in a new moment in time around this type of care delivery. We have an opportunity to harness the great work that's going on in so many different channels around the country. Lauren and Tim's work being two examples of that. And let's not squander that opportunity. That would be my take home. Let's continue to really be innovative around the different ways that people access this type of care, how we define and come together around, comparing apples to apples, ultimately so that we can continue to demonstrate the value, make the business case that this benefits people on so many different levels. So that would be my takeaway.
Thank you. And like the rest of you, I'm in total agreement with what you have to say. You don't know someone until you see what they value, and you see what they value when you see their home and the relationships around them. And that's really what informs you on where their care is going. And I know you're all committed, not just to making sure that acute care stay is done, but that you followed them long enough that they've overcome that they're set on a path of health going forward. And I know that's important to all of us. And that happens because of the relationships we build and all the stories that you've all told about the patients you're working with. Let's keep that up and let's use technology to get us there. So we have time now for some questions and answers. So audience, I see some of you have been putting some questions here. This is your opportunity to talk to 3 rock stars in the industry. So give us your questions. And I see some are coming in. Okay, let's start with the first one I see on here, and it is, what do you think the key to hospital at home success? Oh boy, like this would be like speed round, okay? So if you have to pick one element that you think is the key to success, what would that be? And I'll let you choose who goes first.
Well, I'll go first. Ladies should go first. I would say, unfortunately, it's reimbursement. Reimbursement has to be there. It's very hard to get things done, especially in a hospital environment, if we can't get paid to do it. And so if that stays, it makes a better case.
So reimbursement. And Tim and Patrick, what is it for you? What is the key to success in hospital at home? Either of you want to weigh in?
Sure.
I'll go.
Go ahead, Tim.
Go ahead, Patrick.
Go ahead, Tim.
I'll go ahead. So what I believe is I quoted earlier, or I stated earlier about the CMMI refresh, strategic refresh, where the bulk of the population move into an accountable care relationship. And so as the financial constraints change, as the payment models change, and we move more to an accountable relationship, then that is the key to moving this along. As long as we stay in a payment model where we just, it's just heads in beds, and as long as there's a head in a bed, then everything's good. And we really look at moving people to the appropriate level of care that meets their needs in a way that's cost effective and brings the most value and rewards providers and health systems when they're able to do that financially is the key to expanding hospital at home.
Thank you. I would agree.
I don't have much to add. I think that's the spot on with ultimately the incentives have to align for the accountability to align with the model, and the money follows that, which creates the ability to provide these services, which are so important.
Yeah, and we'll stick with that same topic, and since you're also polite, I'll call on you this time. Let's start first with you, Patrick. The hospital at home, how is it received by hospital executives? And are they excited to collaborate with you? Like, is it a good relationship, or does it feel like you're competing against each other?
Yeah, it's a great point, and it speaks to the conversation we were just having around making sure the appropriate incentives are aligned across the board. I think one of the pieces we've seen is there are a lot of innovative hospital executives around the country who are looking at this and saying that is the future. We got to get on board with that, and there's a lot of benefit to us as a hospital and a health system. Clearly, during the pandemic, there's been an incentive to ensure that inpatient bed resources are allocated in a way that meets the needs of the community. And so there's no doubt that these models have been able to support that, and we've been able to do that with hospital partners in terms of throughput and just making sure the right level of care is delivered to the people who need it most around the country. So I think when you look at things like payment models plus throughput and appropriate use of resource plus innovative systems wanting to be seen in their communities as innovators and being able to expand the services they provide in a new way. Those are the three things that are exciting to hospital executives at this point in time.
Yeah, and that's a great value proposition to present to them, because you're right, all of those elements are very important to them. Tim, I'm going to turn the question a little bit for you. How are hospital executives receiving your transitions of care model? Are they excited about it? Do they feel like they're losing the patient when you actually take them from the hospital and then you provide the care? How is that being received by hospital executives?
Sure. So our approach is to take on their most complex patients, many of which have extended length of stays. And we have our own internal quality assurance metric where our goal is to reduce the average length of stay for those complex patients, which increases our value to the hospital partner. And since we're able to deliver that and seek payment from third-party payers, we're an excellent strategic partner because there's no cost to the facility. We partner with them to reduce the average length of stay and take on their most complex patients, particularly those that have a social determinants of health, behavioral health, substance use disorder, and multiple chronic conditions, right? So there's not many hospital executives that say, I really want a bunch of readmissions for those persons with comorbid behavioral health conditions. And so if we're able to take that on and then drive a value to the hospital, i.e. reduce length of stay and reduce readmissions, we become an excellent strategic partner to help hospitals increase their bottom line.
Thank you. And that's, once again, great value proposition, and you're right. Lauren, over to you. I want to look at this a little bit differently for you as well. In terms of when you deploy a hospital at home, how do you think that affects patient education and caregiver training and all of those elements that now you've shifted to home and to the people at home? What does technology do in that area when you're providing hospital at home?
Well, it definitely gives our providers and the caregivers who are home with the patient a better perspective and understanding, because as Tim was mentioning, you don't really know somebody until you see where they come from, where they live, what their circumstances, what their support system is. And so being able to engage that caregiver in that conversation, either as a discharge or a post-acute visit, and being able to answer their questions and concerns after they're home is a huge difference. We do that through our transitional care center. Rather than, we're handing them papers and sending them home, it takes a little while to figure out, okay, what does this mean? How do I take care of this person? Or how do I take care of myself as a patient? So being able to have that virtual connection and answer their questions and reassure them that they're doing well and, do those quick follow-up visits really makes a huge difference and engages the patient in their healing. and helps them be able to ask their questions and be able to understand how to take care of their care even better. And it's been wonderful for our providers. Some folks who've never had the opportunity to see patients in this way, when you have cardiologists and neurologists that are suddenly seeing their patients in the home virtually, they have a greater understanding of what the need is and what the barriers are that lots of us face when we have a clinical condition.
Oh, that's a great point. That's a great point. They give you a different perspective, gives the provider a different perspective they haven't had. Absolutely. What a great use of technology. A question for all of you, and I'll start with Tim this time, then I'll go Lauren and then Patrick. Are you using wearables at all? Are you? How do you see technology that are wearables and allow people to still be, you know, a little more mobile? Is that part of your strategy with Hospital at Home at all?
So it is.
Tim, are you using wearables?
So it is something that we have tested out, both around fall prevention, wearable devices, as well as, particularly during the height of COVID, those exposed to COVID, we had continuous pulse ox monitoring so that we would be alerted when they desaturated and then could have an early intervention. So we have explored the expansion of that, as well as working with hospitals for those persons who have frequent admissions or ED visits for falls, and then assessing the home, adding a wearable device that assesses for fall risk or incidence of falls, so we have an early detection, is one of the models that we're deploying with the value add of reducing subsequent ED visits for falls.
Thank you. I think that's really important, considering the statistics on falls, and especially with the senior population in their homes, to be able to get that information is vital. Lauren, how about you? Are you using wearables at all in the work that you do?
Not in any kind of broad scope. We have done some specific patient population projects and shown great success, but I'm sure those that are in the audience who work in healthcare systems know how difficult it can be sometimes to deploy new technologies in our environment, but we're working through that. But even just during a virtual visit, you know, we send a lot of our COVID patients who are going home with just a general pulse oximeter. We tell them, go get your pulse oximeter. We're going to tell you how to use it. Tell me what the reading is. And we engage them in that process, which is very low tech because there's some really cool devices out there. But we are looking at that option of how to do that and show the value, again, of why we need to invest in those kinds of resources.
Thank you. And you brought up an important point, but after Patrick answers on wearables, I'm going to come back and let's talk about broadband and the lack of accessibility. Patrick, to you, are you using wearables at all, and how are you deploying those?
Yeah, I mean, one of our advantages, I would say, is we are able to be agile and to quickly pilot and transition amongst the various technology that are out there. I think one of the challenges with wearables is there's such a variety, and it's hard to kind of get a sense and to cut through to which ones are going to provide the highest value for which patients. And so we have done and are doing everything from continuous monitoring in our highest acuity patients that are, you know, sick with an acute illness, where they literally wear a wearable that's monitoring vital signs 24/7 and reporting those into a system, to the types of wearables that Tim was alluding to in terms of monitoring for patients after they're through their acute illness, and what are their risks for falls, et cetera. The punchline for me is we have a long ways to go in continuing to globally, not just at Dispatch, but across the country, around which of these technologies are really going to bring us the highest value, and how do we match those with the appropriate patients. A lot of learning going on there.
Oh, I agree, Patrick, 100%. And I'm going to stick with you with our next question, and it relates right to this. So we could talk about wearables, we could talk about remote patient monitoring, but if there's not connectivity in the home to begin with, and for a lot of seniors and different populations, that could be a real issue. How do you overcome that with Dispatch Health? Patrick?
Yeah, it's a challenge when we have connectivity issues. A couple of things come to mind. One, there's increasingly technologies that are supporting the capabilities of broadband in environments that traditionally aren't getting them. And I think that's one thing we've been leveraging. The other, and maybe this is heresy and a technology focused call, but again, the power of the simple telephone, and not underestimating what a good nurse and a patient who's willing to answer the telephone can accomplish over the course of weeks and months. So those would be my two thoughts. We need better technology to support reaching a broader audience, and at the same time, let's not also limit ourselves in terms of the innovation that we're providing and finding unique ways to reach diverse and patient populations.
Once again, meeting patients where they are. Thank you for that, Patrick. Tim, on to you. In terms of accessibility, you work with a lot of inner city populations and populations on the move. I would think that that broadband is a real issue. How are you overcoming that with your patients?
Yes, so the majority of the patients that we serve have limited access to broadband. And so it is a significant challenge that we face all the time, but they still need high quality care, and many of them need remote monitoring. And so what we've had to do is to move to a posture where any device, any system that we're using in the home has to come equipped with its own ability to link to us, either through cellular or have a broadband capability built in, or else we can't serve the person. I remember very distinctly when we started this work, we're working with a hospital, had frequent admissions for a patient on dialysis. And we discovered that the patient was attempting to do peritoneal dialysis, and they had been evicted from their home and were living in their car and doing dialysis in the car. And so if we don't address the frontline needs of that person, so giving them a device that requires broadband, wasn't first priority for that person, but we needed to address their medical needs. And so we provided them with a device that had broadband capability built in, so we could monitor them and then use that same device as a portal for access to social services so that we could get them housed so that they could get the appropriate medical care.
Excellent. Excellent. Very resourceful. Excellent. Lauren, how about you?
I think, to Tim's point, we work in a lot of rural communities as well, and sometimes that can be a challenge. And so creating access points where people, maybe if they have to go 5 miles away, it's a lot better than going 50 miles away to Tallahassee. Using our primary care system of clinics out in the rural communities, working with our federally qualified health centers, we try to create access points working with those partnerships where they might go to the clinic, but then they can also see their cardiologist, where we've got good broadband access and a device set up. And even for some of those softer services that we know are equally as important. When we shut down to visitors, I think during the second big wave of the pandemic, we created a private room with access points where families were upset and wanted to see their loved one. They could go sit in front of a screen and see their loved one up in the COVID unit or in the ICU because they weren't allowed up there. They might not have had a phone where we could help them do that, so we created a place for them to do that was private. And I think going that extra step, people will engage a lot more if you show that you're going to meet them where they are and help them get the services or see the people that they really need to and want to see.
Thank you. And what an awesome idea. Thank you for doing that. I mean, that shows your heart. And thank you for that, Lauren. And I'm sorry to say this, but the last question goes to me. So on one of the slides for Constant Companion, it shows a picture of Geek Squad. And the question is, one of your slides has a picture of Geek Squad. Is this part of your model? Who helps patients set up their devices in most of these engagements? Well, that's the cool part about Constant Companion. Constant Companion can deploy Geek Squad to come out and actually install, test, make sure that you're ready to go with our home care hub. And they can bring it right to your home, set it up, call back to our call center, make sure every aspect of the device is working, that you have the cellular connection, and we do that all through Geek Squad. It's a partnership that we are very proud of and important for making sure that the technology gets used most effectively and the way we want it in the home. We hope that we can be a service to all of you in all of your endeavors. That's what we do at Constant Companion. We are here to serve you and to serve the people wherever and whenever, whatever part of life they're in. So for all of us here on this today, I want to wrap it up and tell you it's been such a pleasure. I've enjoyed this conversation immensely. I wish all of you tremendous success, and let's continue to push forward in this area. Thank you again for joining us, and goodbye.